Might have to crank up the volume, Chris.
Crank it. Yes. Coffee at midnight, bro.
Right from the Chris Lyon.
The vault of the tune.
There we go.
We're here.
The next big thing. All right, we're going to talk about the next big thing in here in just a few minutes.
Yes.
Welcome back to the MedTech Jam Session, everybody. I'm Mike D, and I'm with my partner, Chris Lyons. Chris, last time we chatted, you were down with the flu.
I know, bro. And I'm 100% recovered and got my running shoes on for AAOS.
Smart. Smart. I think I might wear tennis shoes too. When you run a startup, you don't have to put on a suit or a tie. You can do whatever you want.
Exactly.
Dress code is whatever I decide it is.
We don't have to be corporate. Come on. We paid that. We paid those dues.
Exactly.
Well,
today on the show, we're going to talk about robotics, and it's a hot topic. It's still a hot topic. It's been kind of one of the hottest topics in orthopedics for the last decade, really.
Mm-hmm.
And I remember, and I'm ashamed to say this, but I'm going to say it anyway. When this was back in 2000, probably 7 or 8, and I was at Smith and Nephew, and we met a gentleman who said, "Hey, I've got this robot I want to show you." And I was like, nobody's going to use a robot to do a total knee. I was there with our head of R&D, and we both just looked at each other like, nobody's going to do this. This is just crazy.
And here we are.
And that was Maurice Fair, the founder of Mako.
Yep.
And I, along with many other people, honestly, completely missed on that.
Right.
So I'm not ashamed to admit it. But the Mako robot sort of blazed a new trail for robotics and orthopedics. But where do you think it is now? Where would you say robotics is now? 2026. We're about to go to the academy.
Yeah,
you're listening. The academy probably has already passed. But tell me where you think a robotics is today, beginning of 26.
It's so we've seen one thing happen already, and it's obviously the advent and the big footprint robots coming. On top of that, the bolstering of navigation utilization even more so because of needing that for the robotics and having that in combo. You're going to see a couple shifts. And that's the thing, is that this is a market that, in my opinion, is only going to keep becoming. It's not that it's going to stagnate. Okay. We're probably years away from that ever happening because there's so much area and room for increased utility per robot, not just being a robot for a knee, but how about a robot for all joints?
Mm-hmm.
We'll call it the miniaturization need is absolutely apparent. The affordability need is absolutely critical. And I mean, we're working in this tough healthcare market. And yes, everybody wants a better result. But at the same time, it doesn't matter if you're a physician-owned ASC where you're watching every dime, right? And they're having a hard time with uptake there, okay? Yeah. Or hospital where there are budgets and things of that nature, but, a lot of the strategics have gotten creative with the type of deals they've cut to get their robots in, et cetera, for the implant pull-through.
Yeah.
So I really feel like miniaturization is going to be a big deal. I think we'll call it Intel inside, the AI inside is going to catapult the utilization of these to the next level.
I think you're right.
And that's where we're at right now. We are not seeing, even with Medtronic just coming out and stating with Mazor, the utility and the AI and the elements of that are being somewhat more integrated. Okay. They're about the first to be able to say that. But everybody else, it's going to be a game of fast following, just like Generation 1 was.
Yeah. Yeah, I agree. I think the advent of AI, I think we're in the bottom, not even the bottom of the first inning where this is going to go, because again, totally. the development of AI tools is accelerating at a pace we've never seen before. And how it gets applied to the operating room really remains to be seen. I think so. I'll be very interested to see. There have been a lot of robots in spine and in And in total joints, we saw where Stryker just announced an extension to the Mako, which is kind of a handheld version.
Yep.
Presumably to compete with both Think Surgical and with Smith & Nephew system. I thought that was a pretty interesting move. That caught me a little bit off guard. So it'll be interesting to see how that plays out and what people's response to that is.
Yes.
But an area that has been really largely ignored for robotics is in large bone orthopedic trauma. And it just so happens you and I have a guest today who is solving that problem for all of us.
Absolutely.
I'm going to invite friends, Mohammad Abedin, Professor Mohammad Abedin, to join us. He is the CEO and founder of Robossis, and Robossis is building the world's first robot for orthopedic trauma. Mohammad, welcome to the MedTech Jam session.
Thank you so much, Mike and Chris, for having me on the show.
Now, do you prefer that we call you Professor? Because I know that Mike told me you ask him to do that all the time.
He wants me to call him the Professor.
The Professor. Hey, I'm enthralled with your tech, man. I love what you guys are doing. And you think about trauma. Let's take a little market scope. Let's drill back to 60 years ago. Okay. And it was the bread and butter. Trauma was what put Richards on the map. Yep. It's what put Synthes on the map. It's what put so many companies. And now it's sort of kind of like, it's trauma. It's like, where's the new, right? And I got a feeling, not only with what you're doing, but what other AI technologies I know that are coming in hot to make trauma procedures, let's call it foolproof. Let's call it prevention of non-unions. Okay. And with what you guys are doing, I just love this whole idea relative to the patient positioning. And what a novel approach. I think everybody's going to recognize exactly what that arm is intended to do, but it's your show, bro. Go.
Yeah, Mohammad, give us a little bit of some background information on where did this idea come from, a little bit about you, Mohammad, just kind of start laying the foundation for Robossis, and then we'll kind of get into the details. Yeah.
Yeah, thank you so much, guys. So actually, I started working on this maybe 10 years ago. And, I was working on different robots before. I'm a robotics engineer. I have, design and, work on different types of robots for maybe different purposes or different applications. And everything I've been working was on theoretical aspects, just analyzing the kinematic structure, dynamic structure, control mechanisms, and everything was on paper. Then I remember, one day I met one of my professors, he was an expert in medical devices. And I just showed him one of my designs and said, do you have any application for mine for this robot? Because I know that this robot is outperforming other, parallel robots. It has a huge force insertion capability and, has a very large workspace. So do you have any application for this? And he was, the first time he saw that, he said, this would be a perfect fit for long bone fracture surgeries. And then that was the first time I heard that. And, then he introduced me to another surgeon and I observed that surgery. So that was a surgery on a 2-year-old boy with a broken femur. So before I go to the operating room, the surgeon told me this would be a very easy case because this is a very young boy. He doesn't have very strong muscles and the surgery should be very quick without any challenge or without an issue. But the same surgery took more than 2 hours. The patient, even though he was a 2-year-old boy, lost 1 liter of his blood. And, actually one nurse was pulling the leg from one side while the surgeon was trying to align the bone and, insert the nail. So it had a lot of challenges and a lot of complications, even on that 2-year-old boy. And then I said to myself, it seems there is a real problem and we need to develop something to solve it. And that was actually the start of the journey.
That's great.
Yeah, that's awesome. Hi, everybody. Mike Donahue here. As a medtech leader, you know how important it is to hit the ground running when your new product clears FDA. You need to quickly align and equip your field sales team with training, customer targeting, sales assets, and operational resources that will maximize revenue traction. Well, at Convey Med, we have the app for that. Convey Connect is the mobile-first launch operating system that ensures your field team is clinically confident, culturally aligned, and operationally efficient from day one. With your customized white-labeled Convey Connect app, your reps can train on the go, access agentic AI to identify ideal customer targets, query AI agents to provide intelligent answers to clinical and technical questions from your customers, communicate and engage with both company leadership as well as your teammates in the field, and then just so much more. So if you are interested in learning more about Convey Connect, go to our website, conveymed.io, where you can book a demo and we'd be happy to take you through the app. And now back to the show. And so you got this concept, you learned from an orthopedic surgeon that there's an application here. So then where did you go with it next? Were you already in the States on faculty at Rowan, or give us a little bit of context there?
Yes, I started at Rowan University as an instructor and then assistant professor and then associate professor. And, we started to, work on this kind of project, try to, make a good design for this application to make sure it can cover, all the requirements for this surgery. When I was reviewing this, I noticed that different teams have started to work on making a robot for this surgery starting 2004. That was the first publication I saw that, in Germany. So there have been different teams who have been trying to bring a robot to market for this surgery since 20 years ago, but they have not been successful. Initially, they started with using serial arm robots, similar to what other robots that you see in other orthopedic applications like, Mako or other ones. They have a serial arm. Those serial arms, cannot insert huge forces. They don't have that capability. Usually the max force insertion they have is around 150 newtons or so. But then they started to look at parallel robots, which have more arms and they can insert more forces. The most well-known one is hexapod or Gopher sword, which you can see in those external fixators, that can insert much more force. But the problem with those parallel robots is that they have a much more limited workspace. So you cannot do large rotations with those rings because, you can imagine when you have 6 arms connected to a ring, you have much more limitations in manipulating that ring to different places. So, but what we have, and which is our design, which, we have covered those in 5 patents right now in US and Europe. So we have a parallel robot, but instead of 6 arms, we only have 3 arms. And this new design has 15 times larger rotational workspace compared to the Gopher sword or hexapod. So you can imagine now we have used the benefits of a parallel robot, but we have a much larger workspace, which is required for these surgeries. And we also have an open kind of a structure, so you can just, bring the robot from the top to the patient's leg. So, you have also removed some of those constraints that existed in those other parallel robots. So that's why I think we have the ideal and unique robot that can be perfect for these surgeries. You have a compact solution. You cannot use an industry level robot in the operating room. You have a compact robot. And at the same time, we can insert all those huge forces, more than 2,000 newtons forces. We can convert them to pounds, but I don't know how much pounds would be that. 2,000 newtons. It's a large force requirement and a large workspace, and with sublimited precision. So I think that's why we have everything we need for these surgeries.
Yes.
So these cases that we're talking about, the solution for Robossis, unlike other robotic applications, so the other robotic applications in total joints and spine are sort of navigation plus. Like you're going to have a navigated saw, right? The saw is going to cut the bone. And I know in thinking about, so how would we adapt robotics to trauma? We don't really need to use a saw. We don't really use a cutting instrument. The big problem, the big challenge in fracture surgery is aligning and reducing the fracture.
Right.
So talk a little bit, Mohammad, about how this is what Robossis does, right? This is the big problem that Robossis is trying to solve. Yeah.
Yeah. As you mentioned, other robots, maybe other applications, you only need that precision is probably the most important aspect of the system. But here you need both precision and force insertion, right? Mm-hmm. And you have, for example, your strongest muscles around the femur, you need a lot of force here, and that's why you need both of them together. And that's something doesn't exist in other. So you cannot use another robot and just say, okay, let's use it for trauma. So that doesn't work.
Right. Would that be something, as I think about the use of this, that could take and normalize the average surgeon. And what I mean by that is, regardless of how strong they are, how tall they are, how little they are, all the in between, does it normalize it across the
Exactly.
board?
You know, I remember when I was talking to a surgeon, he said, you have to be an ex-football player to be an orthopedic surgeon because of all those forces. And, you know, when you look at the numbers, you have the lowest number of female surgeons in actually two specialties, in orthopedics and, you know, I forgot the other one. But yeah, in orthopedics, you have the lowest number of female surgeons because of those issues, because you need to have strong muscles to be able to manipulate these bones, you know, and that's a challenge. But now you can imagine you have the robot that can do the work for you and in a much better way. So when you have the robot, then you don't have that over manipulation or under manipulation. So you don't have extra soft tissue damage. You know that how much force you have to exert to make sure, you know, this is moving in the exact same, you know, trajectory you will like, the same displacements. You're not just moving that, you know, faster or slower. So I guess those are all the benefits of, you know, having a robot. I think what we say is that using the robot, we can provide stronger hands to surgeons, and using the navigation, we can provide stronger eyes to the surgeon, you know. So basically, you know, that's, I guess, what we bring to the operating room.
So you have a 3-arm robot you described. How is it attached to the bone?
So a good part here is that, you know, we use the same method they attached, the bone attachment system they use in the external fixators. So basically, the surgeons, you know, in the first cadaver study, I was nervous that how long it's going to take for the surgeon to attach these pins to the, you know, from the moving ring to the bone. Then he said it takes only a few minutes for me. And that was exactly the same thing, because he said we know exactly how to place these pins because we are used to placing these pins through external fixators. And I think that interface is very similar to what they have done before. And it's not going to change the workflow, you know, on. So, and to answer your question, you know, we just have the ring. You only need, let's say, 2 pins, you know, from 2 different angles to connect through the bone. And they also can use, you know, kind of wires, you know, instead of screws. So they have different options, and we want to make sure that surgeons are flexible and they can use whatever technique they prefer to attach the robot to the bone, and then they can just supervise the robotic surgery.
So so this is applicable. So for obviously long bone at this time, I'm sure there's going to be other elements that can come out over time for some of the more short bones. But is it a situation to where internal and external fixation can be utilized with the robot?
Yes, I think, you know, at least for now, what we have, we want to make sure the surgeon can use both nails and plates, you know, so they can use different approaches. You know, we just want to make sure they can do whatever they could do before.
Awesome.
And, you know, yeah, it's just a minimal invasive surgery. Instead of just cutting the bone, you can just make some holes. And even if for a comminuted fracture, you know, you can still, because even if you have a multi-fragmentary fracture, you still need to, the main requirement is to make sure you can have the correct length and rotation between the main distal and proximal fragments. And so we do the same thing, you know, for the surgeons. And so it could be applied to different types of fractures at different fracture locations.
Okay. That's great.
Yeah. What I really come to love about it is something you mentioned, Mohammad, which is it's not a complete change in a surgeon's workflow. The design of the robot is such that before you do anything, before you start putting implants in, you have to reduce and align the fracture. And that's what this does. And the beauty of it is to your point, you attach the robot to the patient in the same way that you might attach a circular fixator. And then it can pull it out to length, adjust rotation, varus valgus, hold it right there. And then what I've heard surgeons tell me is it's like putting a nail in a sawbone. It's just easy. You just slide it in. You just go through the steps. Really easy to do because that fracture has been held rigid and stable by the robot. And so I think the thought process that Mohammad and his team went through. Talk a little bit about that, Mohammad. Talk about the interviews and the process you went to really gather up the user needs for this. Because you talked to a lot of different, you went through a pretty rigorous process.
Yes, I guess one good thing about being at the university here is that we try to attend different programs. Also, we had a lot of grants, and one specific grant that you just mentioned, we were awarded I-Corp grant from NSF actually 2 times. And we interviewed more than 300 people in our customer segment. So we interviewed trauma surgeons, patients with broken legs, hospital executives, medical device executives. Initially, we had some hypotheses. It's interesting. Initially, we thought reducing X-ray exposure is the most important value we bring to the operating room. But after we were done with all our interviews, we thought that has minimum kind of importance for surgeons, and even patients. Patients didn't care about the X-ray radiation. They only care about the scar on their bodies. They want to make sure they have the shortest, kind of scars on their bodies after the surgery. And obviously the most important value we could validate with these interviews was that alignment is the most challenging and the most important factor that we bring to the operating room. Even though we have those other kind of values, it's a minimal invasive surgery, it reduces the hospital stay, reduces complications, infection risk, everything else, and X-ray radiation. But alignment, to your point, Mike, and I remember Dr. Saimet, our surgeon advisor, mentioned that malalignment is the second most common reason orthopedic surgeons are sued. So that's a very real and significant problem.
Yep. Very much so. And I love the fact that you hit on the radiation piece of it, because to me, that's just gravy on top of everything else of what you've created here, because it's still important, right? I mean, everybody thinks about it and so on and so forth, but the docs you're talking to right now are like, hey, look, if I can do this without having to manhandle this patient, I'm in.
Yes. Yes. And that's very important, and I counted the number of X-ray shots they used in one of these surgeries. We observed many surgeries. You may not believe it. It was 500 X-ray shots in one single surgery.
I do believe.
So now you can imagine. Yes, it's a lot. And let's say one of the surgical staff was actually a pregnant woman inside the room. So now you can imagine how much effect it may have on the.
Yeah.
So it's a very real problem. And with navigation and registration, you can technically reduce those number of X-rays to less than 10. So it's a very significant X-ray radiation, reduction.
That's very awesome. Benefit. I mean, that's down to 10. I mean, that's a 50 times reduction.
50 times reduction, yes.
I mean, that's saving lives.
Well, the radiation point is an important one. There are some papers that suggest that female orthopedic surgeons have a much higher rate of breast cancer.
Yep.
And the one obvious difference is they've been exposed to higher doses of radiation through their training and their practice.
Yeah.
So there's a higher level of sensitivity with female orthopedic surgeons, and the lead that they have to wear is very uncomfortable, and this solves a lot of problems.
And Mike, actually, also to your point, we saw some papers that orthopedic surgeon has so much back pain, neck pain because of all the posture, in the operating room, and all those forces and all those heavy leads they have to wear. So those are some, maybe it's not visible now, but those are some of the real issues they have and could be resolved with using a robot in the operating room.
And to that point, you think about how the surgeons are working with the staff to reduce a fracture and the nonstop shots and everything else. Where are their hands and their arms in the middle of doing that? Mm-hmm. They are getting fried in front of the C-arm, Yes. And it's a big deal. It's a big deal. I mean, what you're doing from a speed standpoint is going to be meaningful. From we'll call it tissue disruption standpoint. I mean, reducing a fracture is not just like rocket science, and the tissue damage that can be done in the midst of it, whether it's a super trained crew or not, can be very disruptive to the healing process.
Yes, exactly. And if you don't have that kind of exact alignment, you will have, malunion, non-union issues, and the healing process will be actually, if you make sure you have the perfect reduction, you can help with those other factors too. And as you said, if during the reduction you have more forces, you may cause more damage, to those kind of veins or different, soft tissue.
Yeah. Yeah, I'm sure a video demonstration of the technology is worth 1,000 words.
Yes. Yeah. Speaking of demonstration, Mohammad, I know you are planning a big raise, and you were going out to the LSI conference in a few weeks and bringing the robot. So tell listeners who might be going to that meeting,
Yes.
What are they going to see when they come by your booth?
I guess before we bring the robot to the LSI, we have to first get a check from Chris to start the fundraising.
It's like, okay, Chris is in, so now LSI, you come in.
Yeah, exactly. And then
I hear you're going to match every investor from LSI, Chris?
Oh, hang on.
So yeah, and then we are actually shipping the robot to LSI too. We will have the robot in LSI. We are unveiling our new system, our alpha design in LSI, and we are raising a $5 million seed round now. To go through our FDA pathway. We are working with, Janice Hogan from Hogan Lovells, one of the probably most well-known people in the space, and yeah, I guess we would have a lot of hopefully, good discussions and
I think you will. I think there's going to be a lot of intrigue because there's not a ton of folks out there that know what you're up to. And of course, Mike being close with you and me being around you, this is going to be a big deal, man.
Yeah.
You're going to have a lot. You're going to be a first mover that has a lot of fast followers.
I think what we want to do is that we want to do what Mako did for Striker. Robossis will do with Trauma, God willing.
That is a phenomenal original statement, brother.
Another thing, if you are an investor, I think because Mohammad and his team have been so resourceful and doing what, resourceful entrepreneurs have to do, being incredibly capital efficient. How much money have you raised so far from investors, and how much money have you raised through non-dilutive grants?
So far we have raised around $3 million from non-dilutive grants from, those highly competitive grants from NIH, NSF, and some state programs. And the money we have raised from the capital investor is basically $500,000 from surgeon-led investors. So far we have been focusing on surgeon investors to, increase bring some credibility into the team. So I think we have 5 surgeon investors and 3 surgeon advisors, which are also investors in the company now. Mm-hmm. And so now we are going to reach out to these kind of larger, kind of investors, venture capitals, angel investors to fill out the gap.
What's the amount you're going to be raising?
We are raising $5 million.
Okay.
Seed round.
And I think if you're an investor, you're excited to see how resourceful Mohammad and his team have been, because there's not a lot of equity in the company so far. Mm-hmm. Right. So that's a good place to be, because you'll see at the meeting, you'll see when we unveil the robot at his booth, how close he is to having something that looks like this could really work in the operating room. Mm-hmm. And so, an investment at this stage, because of all the work that's been done non-dilutively, should be very attractive to a seed stage investor.
I would agree. I would agree.
If you look at the precedent, companies that have gotten just before or right at FDA approval have exited for a lot.
A lot.
Yeah.
No doubt. Yeah, I was picturing it under the name of being a startup. I was picturing, okay, how's he going to get the robot out there? It's going to be the family minivan with a small U-Haul.
Throw in the back of a pickup truck and put some tarp over it and
drive
it from Philly to LA.
Yeah.
When I say LA, I don't mean Lower Alabama. Well, Mohammad, in all transparency, I've been involved with the company, and so I'm super biased, but I think you are certainly on to something special. And, I think for our investor friends who will be at LSI, and if you happen to be listening, this is going to be something that you're going to want to be in on. If nothing else, you can get in early. There is no one else working on this as far as we know. None of the big strategics, to our knowledge, and we've talked to them,
haven't
disclosed that they're working on a robot for trauma. They're focusing all their energies on expanding their joints offering, whether it's going into shoulders, going into total ankle, and then expanding into spine. No one is really in the trauma space.
No,
we really do. So Mohammed's point of being what Mako did to Striker and for knees, Robossis really could do for trauma. And that was a multi, 10-figure exit for Mako. A lot of work ahead of us, of course, but Mohammad, anything else you want to share with the group? If people want to learn more about Robossis, where should they go?
Yeah, so first of all, Mike, as you mentioned, we're very happy to have you in our team. We have basically been very grateful to have your instructions, guidelines based on your huge experience in the field. And we're also very happy to have those other valuable team members. And yeah, and as you mentioned, we have also very large markets, right? So we have more than 430,000 only female fractures in the US that require surgery.
Yep.
So we have a very large market. Right now we're focused on femur and tibia for our FDA submission.
Mm-hmm.
And, we may also expand to some other bones. We have a patent on spine, but I guess even just if you think about femur and tibia, we have a very large market in the US and, in the world. And so, yeah, I guess hopefully we have a lot of things to do, and I think we're on the right track. And yeah, let's bring this to market together.
Yeah.
Awesome.
Definitely.
That sounds good. Well, congratulations on getting Robossis so far along on such a lean and resourceful budget with your team, and all the best as you get ready to go out to LSI and kick off your raise. Chris and I are here to help you, and that's going to do it for another edition of the MedTech Jam Session. Awesome. Okay, everybody, check us out on Apple or Spotify, wherever you get your podcasts. Great conversations with amazing founders. Thanks again for listening. We'll see you on the other side.